Shine a light on your research by presenting your work at RSNA 2024. We are looking for thought leaders to provide scientific presentations, education exhibits, and quality improvement reports. Submissions are open February 21st through May 1st, noon Central Time. Submit your abstracts today. Go to rsna.org/abstracts.
Hi, and welcome to the RSNA RadioGraphics podcast. I'm Robert Morris from the University of Mississippi Medical Center, where I'm a musculoskeletal radiologist and Vice Chair of Clinical Operations for the Radiology Department. For this podcast, I'm going to discuss the article, Preventing and Mitigating Radiology System Failures, A Guide to Disaster Planning, from the November-December 2021 issue of RadioGraphics. This article is by Dr. Brian Gibney from Vancouver General Hospital, along with colleagues from Vancouver and Washington State. Disaster planning is an important topic that most people don't like to think about until a disaster occurs, at which point it's too late to start planning. Essentially everyone in radiology has experienced some kind of disaster, including the COVID-19 pandemic and the 2022 iodinated contrast shortage. Natural disasters, mass casualty events, and technology failures are also becoming increasingly common. So it's important for radiology departments and groups to prepare for disasters, and this article gives a great overview on how to start. The authors define a disaster as a serious disruption in the functioning of a community due to a hazardous event. We often think of a mass casualty incident when we think of disasters, which can lead to a surge in patient care needs that can overwhelm the healthcare system, like natural disasters or large-scale accidents. System failures are also a type of disaster, like a power outage from a lightning strike or incapacitation of IT systems by a cyber attack. Patient volume surge and system failures can go hand in hand, like we saw in Hurricane Katrina. Disasters are hard to predict and impossible to perfectly plan for, but risks can be reduced through planning. The goals of a disaster management plan are to understand, prevent, reduce, and mitigate disaster risk and strengthen resilience. A suggested starting point is to expect everything to fail and build the redundancy plan from that assumption. The authors define a hazard as a situation with the potential to cause harm and which can be categorized into natural hazards like a tornado or earthquake, technological hazards like a utility failure, and human-caused hazards like a shooter incident or cyber attack. Hazard risk and vulnerability analysis is a top-down systematic process used in disaster planning to identify potential hazards and to quantify the risk of each hazard on the basis of probability of occurrence and potential impact severity. The steps in hazard risk and vulnerability analysis include identifying potential hazards that could impact the radiology department and how the hazard would affect patients, staff, capacity, and demand, estimating the risk of occurrence of each of these hazards, identifying the specific vulnerabilities to each hazard and current capabilities to respond, planning and directing resources for prevention, mitigation, and preparation. Figure 5 in the article is an excellent depiction of plotting impact versus probability to determine where resources need to be directed. Another method is failure mode and effect analysis, which is a structured qualitative method used to identify potential functional vulnerabilities in the design and operation of a healthcare system. This is a bottom-up approach that helps identify all possible failures in a process and how those failures could propagate up to impact systemic function. In failure mode and effect analysis, a team develops a process map to identify and display the processes involved in a system, and then to look at failure modes for each process to answer 3 questions. Is there one point where failure of a process would be critical to systemic function? Is an effective control measure in place for the failure mode? And can the failure be detected before an adverse event occurs? The idea is to take corrective actions before a failure occurs. The authors define resiliency of a system as its robustness, redundancy, resourcefulness, and rapidity. Robustness is the ability of a system to withstand stress without loss of function. Redundancy is the ability to substitute different elements within the system. Resourcefulness is the ability of a system to adapt to reduce disruption in the system, and rapidity is the ability to quickly respond to and mitigate disruptions. The resiliency of a system can be estimated by using 2 variables: time to survive, which is how long a system can function when there is a sudden shortage of a critical resource, and time to recover, which is how much time it takes to restore adequate supplies of a critical resource. By quantifying each variable under different scenarios, a department can model its ability to operate during a disaster and subsequently recover. In a disaster, the components of the larger system that are at risk are the 3 S's: staff, or personnel, structure, like building, utilities, and infrastructure, and stuff, which is supplies and equipment. In radiology, there is a 4th S, which is software, or IT capability. All of these are interdependent. Figure 8 in the article is an excellent illustration of all the components of the system at risk. The first S is staff. Ideally, the number of radiologists and technologists can be matched to the size of a disaster-related patient surge. Non-technical staff is often overlooked for things like registering and transporting patients when making staffing plans. If an event can be anticipated, it is better to preemptively make staffing arrangements, like if a hurricane is slowly approaching. Any and all communication options should be considered to alert off-call personnel of the need for extra help, and having a system in place already is ideal. Other staffing considerations are the need for parking and transportation of personnel, especially if that is an issue due to road blockages or traffic related to the disaster. If a disaster is going to be a prolonged situation, then staffing needs to be staggered to avoid overusing limited resources and to allow for shift relief. Inevitably, some staff will not be available to work due to the effects of the disaster on themselves or their families, but if additional staff are needed, there are some options like recently retired staff, senior trainees, and staff from surrounding areas that may be available to help. The second S is structure. In terms of structure risks, interruption of electrical services will completely shut down a radiology department. Electrical failure is mitigated through the use of uninterruptible power supplies and generator backup. CT requires the greatest power need in a radiology department, and without a dedicated radiology power outage plan, a facility may not be able to operate a CT scanner. Portable X-ray and ultrasound machines may be the last available imaging equipment if backup power fails, as long as they are charged. Other major structure considerations for disaster planning are water and waste management if the water supply or sewage is interrupted, flooding, which is a particular risk as many radiology departments are often in the basement of the building, fires, which can happen when electrical sources are in close proximity to flammable gases, and heating, ventilation, and air conditioning failures. AC units require a lot of power, but servers, PAC systems, and MRI machines all have to be kept cool to function. Related to both staffing and structure needs is communication. Disasters can disrupt traditional communication channels. Peer-to-peer communication like text messaging can be valuable, but can also lead to spread of unconfirmed rumors. If there's a failure of external communication, then satellite phones may be helpful to communicate with the outside world. For on-site communications, an organized command center is recommended to prevent contradictory communications. And communication is most effective when it is frequent, factual, and clear. Imaging communication issues are a unique problem of the radiology department. So a system that allows manual entry of verbal or written orders increases resiliency and can help detect duplicate imaging requests. Patient identification and tracking can be difficult during a disaster. Pre-registered identification numbers can help to track unidentified patients, and radiopaque ID stickers can help match patients to their images. Electronic reporting may be unavailable, and so a multi-part, carbonless, structured form can be used to document and communicate results. The third S is stuff or supplies. Supply chain resilience can be achieved through supplier redundancy. If there is advance notice of a disaster, then crucial supplies can be stockpiled before the event, and personal safety equipment should be readily accessible in a designated location for the event of a disaster. Gloves, flashlights, crash carts, and other emergency equipment should all be easy to locate. The fourth S for radiology is software or IT. Radiology IT includes the imaging hardware, PAC servers, workstations, voice recognition systems, electronic health records, and all the supporting software and networks. Radiology departments contain the largest number of networked medical devices in most hospitals, which increases the risk of remote cyber attack as a single vulnerable device can give access to the entire hospital IT system. Cyber attacks on medical IT systems have been increasing in frequency, and so the need for cybersecurity is great. Cybersecurity is the state of being protected against criminal or unauthorized use of medical data. The main objectives of cybersecurity are confidentiality, or protecting patient PHI, integrity, which is maintaining accurate and consistent records, and information availability. Focus areas for cybersecurity are user authentication, access control, which is limiting the activity of users to within their required realm of IT access, and making sure that devices are not visible outside of institutional networks. Cybersecurity mitigation measures include regular backups, use of firewalls, network monitoring for intrusion detection, antivirus software, and regular operating system updates. Physical IT security includes locking rooms containing accessible equipment and preventing damage from fire, flooding, and power loss. Organizational cybersecurity requires training for all radiology staff on privacy policies, data leakage prevention, and workplace social media use, all of which must be tested in simulated cyber attacks. If a disaster results in the inability of a radiology department to operate owing to unsafe conditions or loss of function, then off-site solutions may need to be explored. Imaging examinations may be performed at a hospital site other than the radiology department. Out-of-department solutions include portable X-ray and ultrasound units and also mobile CT and MRI units. There are also out-of-hospital solutions, which include alternative care sites such as sports facilities, schools, hotels, and convention centers. And teleradiology, which has increased since the COVID-19 pandemic, can be valuable in disaster situations. Remote teleradiology services can be helpful to report large imaging volumes. All phases of disaster response planning should include both sustaining operations and the transition back to normal function. The temporary situation-specific measures implemented during the acute phase of a disaster should be gradually stood down, and an all clear can be declared when all surge workload and add-on effects have been cleared and a manageable new normal state of function is in place. An after-action review should be done to assess the disaster response and the lessons learned to improve future planning, focusing on people, technology, and processes. System failures should be investigated and remedied. Interprofessional debriefing allows the professional and emotional impacts on staff to be expressed, acknowledged, and addressed, as it can be hard to maintain staffing levels after a disaster due to trauma from the experience or concern for a repeat event. In conclusion, disaster planning is a core facet of modern healthcare practice. Reliance on complex infrastructure makes a radiology department particularly vulnerable to system failures. Disaster risk reduction focuses on recognizing different types of potential failures, implementing strategies to mitigate their effects, and planning response and recovery. Identifying those systems at risk and the potential hazards by using recognized tools allows measures to be put in place to build resilience, to sustain operations during the event, and to transition back to normal function afterwards. This article provides a lot of great food for thought that everyone can apply to their departments. I'd like to thank Dr. Gibney and colleagues for this excellent article. There are a lot of great figures in the article too, so I encourage everyone to check it out. Please rate, review, and subscribe to this podcast. The more our listeners rate and review the podcast, the more it helps to expand our audience. Please visit the RadioGraphics website to read this article and check out all the other great published articles. And thanks again for listening to the RSNA RadioGraphics podcast.